Hi, my name is Jane Picarelli, and this presentation will be describing coronary artery disease. Covered subjects will include topic description, etiology, progression, clinical manifestations, and pathology. The last few slides will be discussing a peer-reviewed study pertaining to the topic. To set the stage for the discussion, I will begin with some background information to aid in topic comprehension. The heart, in all of its splendor, serves as the vital pump that circulates blood and all of its contents like oxygen, glucose, hormones, white blood cells, platelets, and waste throughout the body. Without the oxygen within the blood being delivered systematically, necrosis of bodily tissue would occur, as well as the resulting loss of function that accompanies tissue and organ death. The heart is divided into chambers. The upper chambers are known as the atria, and the lower chambers are the ventricles. Separating the heart's chambers and the arteries and veins that channel the blood to and fro it are specialized valves that allow for unidirectional flow, so the blood keeps on flowing and doesn't become backlogged. The basic process goes as follows. Unoxygenated blood, high in carbon dioxide, flows into the heart from veins from the systematic, which is body-wide circulation. Next, pulmonary circulation occurs as the blood then gets pumped into the lungs from the veins, which restore oxygen and reduce carbon. The now oxygenated blood is channeled back to the heart. As the heart pumps, the arteries carry the now oxygenated blood away from the heart and back into systematic circulation. Despite the fact that blood is constantly flowing from the heart tissue is unable to gather its oxygen and nutrients from the blood passing through its chambers because the heart muscle wall does not allow for oxygen to diffuse through it. This is where the coronary arteries, located outside of the heart, come into play. They are specialized blood vessels that provide the supply of blood that the heart needs in order to function. This is a pictorial representation of the coronary system, and you can see the arteries on the outside of the heart are the ones that involved in carrying the blood to the heart that the heart can actually use for nourishment. Coronary artery disease is where these specialized blood vessels that we just described that provide blood for the heart develop some sort of damage that usually leads to a plaque being formed that can eventually lead to a blockage of blood from reaching the heart. Without this crucial blood supply, the heart tissue starts to die and functions become lost. About half of the fatalities in the United States are attributed to coronary artery disease, because as it progresses, it can lead to a heart attack. Not all coronary artery disease stages lead to a heart attack immediately. Some stages are rarely even associated with symptoms, which we'll get into in a minute. However, as the disease is usually progressive in nature, any degree of coronary artery disease is a problem. Depending on the degree of damage to the blood vessel, symptoms can either be non-existent, transient, chronic, acute, and/or fatal. As I begin to describe coronary artery disease progression, I'll take a brief moment to explain the difference between what is commonly known as good cholesterol and bad cholesterol. Good cholesterol, also known as high-density lipoproteins, or HDL for short, are necessary in the body and actually can help get rid of the bad cholesterol, which we'll talk about in a second, by transporting it back to the liver to get rid of it. This good cholesterol, that HDL, by helping reduce bad cholesterol accumulation in the vessels, actually helps reduce the risk of coronary artery disease. Foods such as avocados, olive oil, salmon, and nuts help raise levels of HDL, the good stuff. Contrary to HDL is LDL. The LDL stands for low density lipoproteins and is what many individuals are thinking about when they hear the phrase bad cholesterol. So why is bad cholesterol so bad? The composition of LDL, low-density lipoprotein, the bad one, makes it a prime candidate for adhering to artery walls due to its ability to bond with arterial protoglycans that in essence trap it in the wall. These LDL molecules are also more prone to becoming oxidized as compared to HDL, and when it does become oxidized, it triggers a process that signals certain white blood cells, such as monocytes, to come into the damaged area. According to a study in atherosclerosis, published in 2016, in addition to promoting the expression of molecules involved with cell adhesion, meaning making those cells more quote-unquote sticky, the LDL can also encourage the monocytes to differentiate into a macrophase. This is an issue because it creates inflammation, which increases swelling, and generates enzymes that try to break away at the plaque, which may seem good, but can cause it to rupture. If you look at the image to the right, which represents a blood vessel, there's erythrocytes, the red blood cells, monocytes, the white blood cells, and the cholesterol is shown there in orange. At the site of any damage, this sticky LDL goes to the wall of the artery and starts accumulating. In addition, it recruits certain type of white blood cells that, in addition to adding bulk to the plaque, trigger inflammation and cause increased swelling. Look at the picture to the left. The milky-looking formation is representative of plaque building. That plaque is a mix of cholesterol and white blood cells. Although it looks rather large, blood flow can actually flow freely, both at rest and during exercise, so no symptoms are felt. So accordingly, coronary artery disease at this point is called asymptomatic coronary artery disease. Now, what do you think happens as that plaque enlarges? As one may expect, the greater the size of the plaque and therefore the more advanced the disease, the more the patient becomes symptomatic. In the next main phase of CAD, which is coronary artery disease, the plaque gets so large that even though the blood can still flow freely through it while the person is at rest, complications do arise during exertion. This is because exercise leads to vasodilation, which reduces the diameter of the vessel. In the case of this stage of CAD, when there is already a decreased passageway for the blood due to the plaque, further constriction, as induced through exertion, further hinders the blood's ability to flow through the vessel. This results in the patient feeling chest pain called angina pectoris with exercise. This phrase is termed stable angina because it can be predictable and one can stabilize blood flow by putting the body at rest. Death at this stage is usually only due to situations in which a piece of that plaque broke off and formed a clot. This would be termed coronary thrombosis, and that's what you can see on the image to the right. When there is insufficient blood flow, even with rest, to meet the body's oxygen demands, coronary artery disease at this stage coincides with unstable angina, which causes more persistent pain, indicating the heart is consistently not receiving enough blood and oxygen from the coronary arteries. Plaque buildup and the large clots that easily build up result in hindering blood flow to a dangerous extreme. Without surgery to remove plaques or medication to break up clots, the heart will surely not get enough oxygen and the tissue will eventually die, causing an array of fatal cardiac pathologies, just as you could see here with this image showing a myocardial infarction. This is why prevention and testing is so critical. The following data listed on this slide as a chart is from the U.S. Department of Health and Human Services from the Centers of Disease Control and Prevention. The following tests and procedures are some of the ways to catch coronary artery disease, even if the patient isn't currently exhibiting a symptom. Imaging studies such as a chest x-ray can be performed, or a coronary angiogram, which is an x-ray with or without dye. Exercise stress tests and EKGs monitor the electrical activity of the heart while one is performing exercise and at rest, and an echocardiogram uses sound waves to generate an image of the heart. This is a little chart that I created to show some of the treatment options and prevention of disease progression with CAD. Diets low in sodium, diets that have fruits and vegetables and high amounts of that good cholesterol, the HDL, along with regular exercise and good lifestyle choices can help lessen disease progression. Just reducing salt alone prevents excess water retention and can lower blood pressure. As far as medications, both aspirin and to reduce the likelihood of clotting, and medications that lower cholesterol, thus lessening the availability of that quote-unquote sticky molecule from sticking to the wall in the first place, help reduce the likelihood of disease progression. Thrombolytic medications are used to break up pre-existing clots, and then surgeries like angioplasty opens the vessels even more by inserting a catheter and a balloon into it, and then a coronary bypass is where they basically redirect the blood flow around the affected artery. Next, in accordance with the topic of coronary artery disease, I will be discussing a peer-reviewed study published in the Journal of Clinical Cardiology. This was performed with the hopes of identifying early indicators and risk factors associated with coronary artery disease. The study was conducted using 814 participants. The parameters included age, anatomical sex, body measurements, average blood pressure, heart rate, pre-existing conditions, and medications taken, if any. The patient's status as a smoker versus non-smoker was also included. The research was specifically interested in determining if there's a correlation with a specific low-density lipoprotein type of cholesterol known as lipoprotein A. I will discuss on the following slide why the researchers chose this as the independent variable. Coronary artery disease progression is indicated by both laboratory tests and 2 computerized tomography coronary angiograms. An imaging technique that displays the arteries was the dependent variable. The conclusion reached will be discussed on a later slide. The reason researchers chose lipoprotein A as the suspected indicator of coronary artery disease is because it's a low-density lipoprotein, which, as discussed earlier, is the bad type of cholesterol. Low-density lipoproteins have the ability to add plaque formation because they are attracted to artery walls and become oxidized. Macrophages come to engulf them and turn them into inflammation-promoting foam cells. According to the article, lipoprotein A has an additional protein that makes it even more pathogenic than normal low-density lipoproteins. This additional protein is called allopoprotein B100. Initial participants were separated by their baseline levels of this protein, the lipoprotein A, as shown in the image from the study. Measurements of lipoprotein A were conducted by laboratory tests in milligrams per liter, with one group having below or equal to 300 milligrams per liter, and the other group having a baseline of greater than 300 milligrams per liter. This was important so that the progression of coronary artery disease can be measured along with increased amounts in lipoprotein A to determine correlation. The conclusion of this study determined that there is indeed a positive correlation between levels of lipoprotein A and progression of coronary artery disease. It is important to note that the imaging was performed at least twice per participant to see disease progression, not just the absence or presence of the disease in the individual. The image depicted on this slide was taken directly from the journal Clinical Cardiology, Volume 44, Issue 11, that published this study. Included in the results are the baseline Genesee score, which is an indicator of the degree of coronary artery disease, setting a score of 0 to indicate the absence of the condition, as well as the changes in Genesee score from one test to another at a specific time interval for each patient group, those with lower levels of lipoprotein A and those with higher levels of lipoprotein A. The results showed that there was more of a raise in Genesee score, meaning more disease progression, in the group with the higher amount of lipoprotein A. That was the group with above 300 milligrams per liter. This shows that there is indeed a positive correlation between lipoprotein A levels and progression of coronary artery disease. The significance of this study is that the information gained from it can lead to future diagnostic procedures that may provide earlier notice of coronary artery disease to give patients more of a fighting chance to prevent its progression, possibly through changes in diet and lifestyle.